Everyone, and welcome to today's program of Resident Smart Learning, an ISU webinar. And today's webinar is being conducted and designed and entirely conceptualized by Dr. Keval Patel, who is, a very well-known urologist in Ahmedabad, and he has a special interest in surgery of CA penis. And the topic for today is inguinal lymph node dissections and carcinoma penis, a critical review of literature, videos, and case discussions. So I wish him all the best for the seminar and ask him to start the proceedings of the seminar. Thank you.
Thank you, Sujata madam. And I wish good evening to everyone. And I thank the ISU, especially Sujata madam and Chawla sir, for giving me this opportunity. As we all know, Indian School of Urology is the educational wing of Urology Society of India, and it has always been a front runner in educating the students. I feel privileged today for being given this responsibility of conducting this webinar of dissemination of knowledge regarding carcinoma of penis. The broad outlook of the program will be initially we'll be having dedicated lectures by 3 speakers, both national and internationals. That will be followed by practical learning through videos by 2 eminent international surgeons. And then we'll have some churning of knowledge by latest publications and their critical reviews. And lastly, we'll have some case-based discussions and practical scenarios. So the first talk is Dr. Benjamin here?
I am here. Can you hear me?
Okay, so I think he's still struggling to join. So let us start our first talk with
Sir, he's here, sir. Sir, he's here.
Sorry, he's here? Okay.
Yeah,
Can you hear me?
we can hear you, sir.
Yeah.
Okay.
Lovely. Sorry
that,
about that. I've had awful Wi-Fi problems. My apologies.
Guest international speaker, Dr. Benjamin Ayres from UK. So he's a consultant urologist specializing in penile cancer in St. George's University Hospitals, London. In UK, they have centralized penile cancer care since 2001. Last year, they saw 140 new penile cases at St. George's. He also specializes in bladder cancer. He is on a trial management group for penile and bladder cancer trials, including IMPACT and WellRAD for penile cancer. He is also part of EAU ASCO penile cancer guideline panel. He works with charities and patients promoting awareness and advocacy in penile cancers and has supported online support groups. He is also on BAU's Uro-Oncology Committee and is an BAU's educational lead for medical students. He is a lead for surgery at St. George's Medical School. He supports the educational work for Global Society of Rare Genitourinary Tumors. I welcome Dr. Benjamin Ayres. And now over to you, Dr. Ayres. Hello, can you listen us, sir?
Share my my talk, I hope.
Hello.
Where is it coming up on here? Hello, can you hear me? Can you hear me?
Yeah, I hear you.
You can hear me. Brilliant. Are you able to hear me,
Is
Dr.
he
Patel?
unmute? Dr. Ayres, Dr. Benjamin Ayres?
I can hear you clearly.
Yeah, we can hear you, sir.
Lovely. Thank you. I'm just trying to share the screen.
Dr. Ravimohan?
Yeah, hi.
I cannot listen Dr. Ayres. Is he speaking?
Yes, we are able to hear him.
So has he started sharing his screen?
Can you hear me now?
Not yet. He's trying to.
I'm trying to
So
share
I am not
it.
able to listen. Why?
I'm trying to. I've just got to turn Zoom on to allow it to happen. Okay. Sorry, the security's asking me to quit and reopen Zoom to be able to share my screen. So I will be back with you in 2 seconds. let me see if I can share my screen now. There we go. It's allowing me to. I'm sorry for the delay here. Can I just check you can see my screen? And that you can hear me loud and clear.
But it's the
We can
last part
see.
is yeah. Now we can see full.
Yeah. You can see it full, and let me just check it's moving. Is it moving through all right?
All right.
Is the talk moving?
Yes, yes, it's moving.
Yeah. Brilliant. Well, thank you very much, and apologies for the IT issues. Thank you very much for inviting me to speak to you this afternoon or this evening over in India around predicting inguinal lymph node metastasis, current status, and future perspectives. These are my potential conflicts of interest. My only paid conflicts of interest are around bladder cancer. So hopefully this talk is without any conflict, other than that it's what I do day in, day out. So what I thought I would do is talk to you about why it's important we predict lymph node metastasis in penile cancer, how we do it, when we do it, and what the future might hold. And the first thing that is really important around penile cancer is to think about the tumor and the nodes as separate entities, because when it comes to control, but trying to preserve cosmesis, form and function where you can, in terms of prognosis and survival. So why is it so important that we try and find out whether patients have involved lymph nodes or not? Well, lymph node positivity in the groins is the strongest prognostic indicator for cancer-specific survival, as I've just said. And this is impacted on by the number of positive nodes one might find and whether or not there's extra capsular spread. So if you have more nodes or if you have extra capsular spread, it's more serious. We know that patients that undergo inguinal sentinel lymph node sampling based on this big, large USA National Cancer Database, we know that men that undergo sentinel lymph node sampling have better survival than those that don't. Now, unfortunately, only about a quarter of the men on this database, and these were PT1B to PT3 penile cancer, so the ones that one would expect surgical staging of their groins to be done, only a quarter in America underwent sentinel node sampling, and that was associated with a higher age, omission of sentinel nodes was associated with older patients, those that were more comorbid, which might be understandable, lower stage of disease, those with Medicaid. But it showed that if you have your sentinel nodes treated, you have better survival.
I think we have lost Dr. Ayres. Ravi, कुछ करना है?
Yeah. I don't know, ma'am. The Keval can answer that because I don't have his contact.
Keval?
Okay.
My apologies that I got kicked off then.
Okay.
Let me reload it back up. My apologies for the internet. as I said, 1-year cancer-specific survival is based on systemic therapy, and there haven't been major breakthroughs there, although there are some exciting areas now with immunotherapy. But what we did see was better 5-year cancer-specific survival from around somewhere between 73 to 77%. And the reason there's a range is because there was some missing data on patients pre-centralization, because we didn't have a prospective database, so we were relying on Office of National Statistics data, to an 85% survival post-centralization. So we did see a big benefit with centralization in terms of survival, and we think that that is in the majority down to the work we've done with inguinal sentinel lymph node sampling, and bringing in dynamic sentinel lymph node sampling with our centralization. So how do we go about inguinal sentinel lymph node sampling, or how do we go about predicting those patients that may have positive inguinal nodes? We know that 60 to 70% of invasive penile cancer presents with impalpable nodes. We know that about 20% of these patients will have micrometastatic disease. And we know that ultrasound scan and CT scan do not have adequate resolution to detect small volume disease. So if we were to do groin dissections on all these patients, there would be a high rate of overtreatment and morbidity. However, if we were just to watch them, this study from 2005 suggested that if you watch a node appear, then 5-year survival is significantly impacted and reduced from about 85% down to 35%. So we know that we want to try and pick this disease up in the groins when it's micrometastatic if we can. As I said, imaging studies are not good enough. We looked at our own data of ultrasound scan, and it's got a sensitivity of 52%. We know that the resolution of CT and MRI is only about 8 millimeters, and PET-CT equally is inadequate. And here are 3 studies that looked at PET-CT, and the sensitivity ranged from 20% to 89%, but the biggest study only had 20% sensitivity. So again, PET-CT is not good enough for picking up micrometastatic disease. We know that you can use risk-adapted nomograms to watch patients. We know that very low-risk disease, grade 1 TA or T1 disease, has a very low risk of metastasis. So these patients we would watch. Equally, G2 T1 has a fairly low risk of metastasis, a 6% risk. So again, one might argue surveillance of that, although we will discuss sentinel node sampling with patients with G2 T1 in our practice. And T1 G3 has a much higher risk. And so really this is the group that we should be looking at performing surgical nodal staging on. But this statement here, if based on a large prospective study, even if you were to go ahead and do groin dissections on all those that were high risk, 77% of patients would still have a bilateral node negative prophylactic groin dissection with high morbidity. So what can we do? And this is where sentinel lymph node sampling come in. Just to say, can we observe those G2 T1s? This is data on 550 patients from 6 European centers, and it showed that overall in all G2 T1, whether they had lymphovascular invasion or perineural invasion, but technically those would be T1B. But in G2 T1, if it was lymphovascular negative and perineural invasion negative, i.e. G2 T1A, then only a 6% chance of nodal disease. But once you start getting into the T1B with lymphovascular invasion or perineural invasion, the chance of finding nodes is much higher, 22 to 30%. So the concept of sentinel lymph node sampling is that the embolization of the micrometastasis to the lymphatics, it spreads in a stepwise and predictable way. The first lymph node then acts as a filter. And so if you remove that first lymph node and it's clear, then the other nodes should be clear. You only get a false negative if there's a technical problem, or if that first node is so full of tumor that it's bypassed in the chain, and the next node becomes the first node that the drainage goes to, and that's why you might get this false negative, and that's why ultrasound imaging alongside sentinel lymph node sampling is important. The pioneers of this in Europe were Simon Horenblast in Amsterdam, and my colleague Professor Watkin here at St George's Hospital in London. And early studies showed that dynamic sentinel lymph node sampling was effective with 94–95% sensitivity. And then we published this paper in St George's, 500 inguinal basins over the first 6 years of our experience. And again, only had 4 false negative studies giving a 94% sensitivity and a low complication rate of 7.6%, which is much lower than one might get if they were doing a groin dissection. So surgical staging of the groins is important to pick up micrometastatic disease. There's no imaging that can replace it. And if you use dynamic sentinel lymph node sampling, you can do it with a high sensitivity and a low complication rate. And as I've already shown you, it leads to better survival. Clearly, I appreciate that not all parts of the world have access to sentinel lymph node sampling. So if you do need to do groin dissection, if you do need to open the groins, and again, we would recommend that you have this surgical staging, then one does a modified template as outlined in the diagram there on the left. You do careful skin flap dissection at the level of Scarpa's fascia. You preserve the fascia on the muscles, on sartorius and on the adductor longus. You preserve the saphenous vein, and you don't do a sartorius flap with the aim of reducing the morbidity of that surgery. And then you can take it even one step further and do video endoscopic surgery. And this is data from the UK showing wound infections reduced from 68% to 6%. Lymphocyls were similar, length of stay reduced, and lymph node yield, so the oncological impact was similar. And we currently have a randomized controlled trial open in the UK looking at this further. So what I've said to you is evidenced and within the ASCO and EA, the recent EAU and ASCO guidelines. So as you can see here, it talks about CT, PET-CT, and MRI unable to detect micrometastasis, and therefore, as it says here, surgical staging of CN0 patients and sentinel nodes has been shown to have a high diagnostic accuracy. And if we look at the next form of recommendations, again, for CN0 patients, if there are no or suspicious nodes at physical examination, offer surgical lymph node staging. And when surgical staging indicated, offer dynamic sentinel lymph node biopsy. If that's not available, we'll then offer inguinal lymph node dissection, open or video endoscopic, taking into account what I've said about trying to reduce the morbidity. When should we do the sampling? Well, there's weak evidence that we should do it within, we should make sure that all lymph node surgical treatment is completed within 3 months of diagnosis. So personally, I try and do the sentinel lymph node sampling at the same time as the primary tumor, but there will be some cases where you're not entirely sure of the diagnosis, or logistically you can't do it at the same time, and we will delay it then, but we try and do it within 3 or 4 weeks of the primary surgery if that's the case. So the future. Nomograms are starting to come in. So this paper looked at lots of different risk factors, clinico-pathological and biomarkers, and found a higher odds ratio associated with nodal disease across quite a few different factors. And if you start pulling these sorts of things together, you can start to develop nomograms that, if you look at the ROC curves there at the bottom right, is not too bad, and so might help you start to predict those patients. But at this stage, these are not in full clinical practice. They still need validating. They're based on retrospective data. If you do find lymph nodes positive in your sentinel nodes, do we always need to go on and do a completion groin dissection? Can we reduce morbidity by saying sentinel node sampling is enough? Well, this is what we looked at across the Netherlands, Belgium, and the UK here. And we found that even with the smallest micrometastatic disease, you still have about a 10% risk of additional nodes being positive. So again, it's about shared decision-making with the patient. I don't think you can safely remove completion groin dissection, but clearly there's some data here that shows that if you have more nodes positive and bigger focus of micrometastatic disease, you're more likely to find further positive nodes in the groin. And what about novel tracers? Well, here's pictures from my colleague, Oscar Brouwer in the Netherlands Cancer Institute, showing the use of ICG to help identify the node under infrared at the time of sentinel lymph node sampling. This is supposed to reduce your false negative studies even further. And there's some interesting data in the literature, all small numbers, so very difficult to draw a conclusion, but the MRI and magnetic particles, ion particles, may be able to help us identify these micrometastatic disease. So perhaps there is a role for imaging in the future with magnetic ion particles. So my take-home message, and again, I'm really sorry for the Wi-Fi problems at the start, is that nodal status determines prognosis. You should go ahead with surgical staging of the inguinal nodes if the cancer is T1b or higher. As I say, G2, T1a, the risk is about 6%, so I think that's on a case-by-case basis. I would strongly argue that dynamic sentinel inguinal lymph node sampling is the most effective way of doing this with low false negative rates. It reduces morbidity and results in survival advantage, although I appreciate that non-European, non-high volume European centers, people have struggled to get the low false negative rates with dynamic sentinel lymph node sampling. And in the future, we may rely more on nomograms and novel tracers. So thank you again for inviting me to talk, and I'm really sorry that my Wi-Fi issues means that you're now running late. My apologies.
Yes, thank you, Dr. Ayres. Welcome. We were not connected till now.
My pleasure. Thank you. I'm happy to take questions if you want me to. I don't know what you would like to do.
Okay, sir. So I'd like to have some questions for you. First is, what is your take on triple dye dynamic sentinel lymph node biopsy? Do you think will that increase the sensitivity and decrease your false negative rates?
What do you mean by triple dye? You mean using the ICG as well?
Yes.
Yeah, so
ICG and methylene blue.
Yeah, so I think the ICG replaces methylene blue. You don't use the methylene blue as well. I think because it's tagged to the tracer, it makes it more accurate that you're going to find the node that's taken the tracer up. I think you're still at risk of getting false negatives if you've got a lymph node that's really full of a lot of cancer and therefore you're getting a skip. But one should pick those big lymph nodes up either with ultrasound or CT imaging prior to the surgery. So the experience from Amsterdam and those of us that have started to use ICG is that it does help you identify that node more than the patent blue or the methylene blue does. So I think from a technical point of view, it makes the surgery more reproducible and therefore hopefully lowers that false negative rate.
Secondly, sir, many times while doing sentinel lymph node biopsy, whatever dye we use, most of the times we are unable to trace, and while dissecting it, we find that the tracer, it comes out of the lymphatics, or the lymphatics are visualized, which are not usually may or may not be positive. So how to overcome that, or what is your technique of overcoming this?
So you don't find any lymph node that's radioactive when you're doing the dissection. Is that what the question is? Sorry.
No, my question is, while we are dissecting, we incidentally injure some of the lymphatics and the dye spills over the entire area. and then we are unable to find what is the positive lymph node. How to get over that?
I must admit, I haven't come across that problem. I do know that we get some lymphatic spill because we see the blue dye starting to come out when you do the skin dissection. You've got some very superficial lymphatics there, but it doesn't interfere with our pickup with our gamma probe, and it doesn't interfere with the lymph node remaining blue. I think my advice would be, if that's a big problem, can you change the dose perhaps of the injection you're getting, so you know that the lymph node is got a high enough dose for you to pick up with your sentinel lymph node gamma probe. And I think the other thing is you need to stick to anatomical principles. So most of the time, the sentinel node is somewhere within that medial upper compartment of Dressler's zones, although we know that it can be in the lateral. I think lots of studies have shown that you never experience sentinel nodes in the inferior Dressler zones. It's always the superior, either the medial or lateral. So again, by sticking to anatomical principles, hopefully you can identify the node.
So do you use SPECT in all of your cases to localize the lymph nodes, and how does it help?
Yeah, so we do have SPECT CT here. We used it when it came in as a new toy for our radiologists. We used it, and yes, it helps anatomically show you where the node is. But we felt that it didn't actually improve our accuracy. As I say, I do about 100 patients. I treat about 100 patients with sentinel lymph node sampling a year. So our experience is, every week we're doing the technique, and we found the nodes regardless of SPECT CT or not. So to save some money, to save the British taxpayer some money, we stopped using SPECT CT and just used plain lymphocygnograms. But yeah, it helps with identification. I agree.
Yeah, and my last question, sir. Do you feel that with minimal invasive techniques coming off and more robots coming into picture, do you feel that we can still remove the superficial lymph nodes, biopsy them, or send them on frozen section? I mean, my friend Dr. Professor Ravimohan had asked this also. Can like avoid sentinel lymph node biopsy at places where they don't have that facility?
Yeah, so I mean, the first argument I'd make is I think a sentinel lymph node sampling is less morbid than a robotic or video endoscopic dissection. So I think if you have access to sentinel nodes and you have low false negative rates, I would strongly encourage people to use that. I think that is the less morbid operation. But I think if you don't have access to it, then yeah, do a modified groin dissection and send the nodes off for frozen section. What I would say is that when our pathologists sample our sentinel nodes, they slice them very, very finely. They use lots of different immunohistochemical analysis, more so than they do with a groin dissection. So the process of a pathological process of sampling sampling sentinel nodes is of a higher standard than a groin dissection, and clearly you won't replicate that on a frozen section. So you may miss some of that microscopic disease. We've had some patients where they've picked up 1 or 2 cells. Now, whether that makes a big difference clinically, as I said, we tried to look at our sentinel nodes and whether you always need to go on and do a groin dissection if you find a small amount of disease. And as I said, if you drop to micrometastatic, less than 1 or 2 millimeter, then the risk of further nodes is around that 10% mark. So it doesn't drop to 0, but the risk is lower than in other situations. So you might argue, well, if you missed a few small cells on frozen section, does it really matter? We don't know. So I would talk to your pathologist about how they're going to sample. Clearly the frozen section is one thing, but then after they've done the frozen section, how they're going to use immunohistochemistry and very fine slicing, whether they're going to replicate the pathological sampling that we do with sentinel nodes.
Well, Dr. Ben, that leaves with such a intriguing thought of detecting micrometastasis and then correlating those micrometastasis with probability of other lymph nodes being positive. Like that's a very good idea. And I thank you, Dr. Ban, for being here. And I request you to be online because we are going to involve you in further of many of our sessions. So kindly stay online. And with that, I invite our next speaker, Professor Ravimohan, who is professor at PGI Chandigarh, to present his talk on pelvic lymph nodes management. Yes, Dr. Ravi.
Yeah, hi. So, thank you, Keval, and Indian School of Urology for this opportunity. In fact, I was thinking that I was supposed to talk as after the videos are played, and I prepared in that line, but nevertheless. So my topic which you had given was pelvic lymph node management, the Achilles heel in management of penile cancer. So I have nothing to disclose. And that's why I started with, I believed that already the lymph node dissections were done either by open or minimally techniques. And that's why I started with pathological node staging, because mostly for students. So I just want to rebrush this, that pathologically, the AJC's 8th edition, which is the latest one, defines that up to 2 unilateral inguinal nodes. Just remember 2 unilateral inguinal nodes without any extranodal extension is pathological N1. Pathological N2 is 3 or more unilateral or bilateral, any bilateral without extranodal extension. So any extranodal extension qualifies nodal involvement as N3. Inguinal lymph node metastasis. Now in India, I think we deal mostly with little more advanced stages. In fact, even to look for a patient of sentinel lymph node biopsy would be a rarity. We would mostly have larger lesions and high grade lesions where we actually end up doing a formal node dissection and many of them pelvic node dissection. So why I think Keval actually labeled it as Achilles heel, because most of the time after doing bilateral inguinal node dissection for XYZ reasons, you are so tired that you will not actually go into pelvic lymph node dissection. Most of the time you try to avoid it, and sometimes the patient also tends to forget it. You don't have any good imaging. Well, neither the CT nor the MRI, which is very sensitive. Somehow PET has come in, but PET is also not found to be extremely sensitive for detecting pelvic nodes. They may appear positive, but they may not actually be positive. So we largely rely on clinical and pathological parameters to say that whether pelvic lymph nodes are involved or not. Now, why it is important that we need to predict, because involvement of pelvic lymph node itself is a poor prognosis. You've done a wonderful surgery on both sides, done a good penile cancer management, a very nice meatus and all. But then if you have not managed pelvic nodes, this patient is not going to survive. So you see 17 to 62%. That's a huge change with presence or absence of pelvic lymph nodes. And what are the other predictors of poor survival when with pelvic lymph node involvement? Is bilateral are more worse than unilateral, and more the number of positive nodes, worse is the prognosis. Now, having understood that, let us understand what are the predictors of pelvic lymph node, because this is the most important thing to understand so that we can do a right treatment at the right time and not miss out on that Achilles heel. Now, presence of extranodal extension on the inguinal lymph nodes or more number of positive inguinal lymph nodes. These are the two things which define as the most important predictors clinically. There are other studies which have shown that P53 immunoreactivity, inguinal lymph node density more than 30%, or a high-grade lesion, they might also help in predictors. And as Dr. Ayres mentioned in his talk, in future we might actually have a nomogram, which will also help us to predict pelvic lymph node involvement. But at this point of time, presence of external extension and number of positive inguinal nodes, these are the two important parameters which predict positive risk of pelvic lymph node involvement. Now, once you know that there is a risk of pelvic node involvement, let us identify what are the further predictors or ipsilateral versus bilateral. So when one or two nodes are involved, and in fact, this is from a systematic review by Dr. Myers is one of the authors in that, where they showed that 1 to 2 lymph nodes, the cumulative incidence of pelvic node metastasis is 0 to 6.5%. And the moment you cross beyond 2 nodes, it suddenly increases to 33 to 67%. So imagine just one node, it changes the spectrum completely. Also, when the inguinal nodes in a PN2 disease, the 3-year CSS is significantly better when performed when a pelvic lymph node is performed. So the recommendation across all the guidelines is that one must perform pelvic lymph node dissection when there are more than 2 nodes, because the moment it crosses number 2, suddenly the risk increases. So it is recommended that perform pelvic lymph node dissection when there are more than 2 inguinal lymph nodes. Now, what are the predictors of bilateral? Although the literature is not robust here, but there's only one study, but it more than 4 or bilateral positive inguinal lymph nodes predict a bilateral pelvic lymph node mets. And bilateral pelvic lymph node mets has pelvic lymphadenectomy has a better superior disease-free survival. And hence, although we don't have a huge literature to answer whether to use unilateral or bilateral, there are authors who have done a selected unilateral and a complete a template lymph node dissection on the involved side and a selected lymph node dissection on the non-involved side. But as a practice in our institute also, we would do bilateral pelvic lymph node dissection in almost all cases whenever we are doing a pelvic lymph node dissection. Although the crossover is not common, but then crossover from inguinal to inguinal is common, and hence, and you're reaching the same area, you don't want to approach the same area again and again. So we typically would perform a bilateral node dissection. Now, this is the standard flow. I think there's nothing much has changed in management of penile cancers except for a huge sentinel lymph node evolution in sentinel lymph node biopsy. So anytime you have more than 2 positive nodes, perform a pelvic lymphadenectomy. Even the NCCN guidelines say the same thing, that more than 2 positive nodes or external extension, you must perform pelvic lymph node dissection. Now, what is the extent of lymph node dissection? I think the extent is same as we do for a standard node dissection of bladder cancer, except that you go a little more lateral to the artery and try to bear the artery, try to bear almost up to a little more of the psoas muscle as well. Otherwise, it is external iliac lymph node group, the obturator group, the internal iliac group, and the presacral group. So that is the extent of lymph node dissection of pelvic lymph node dissection. Now, once you've done the pelvic node dissection, is there a role of adjuvant role of adjuvant therapy? So, pelvic lymph node micrometastases are present even in up to 16 to 20. This number 20 hovers very well in penile cancer. So 20% risk of missing sentinel node. Similarly, pelvic node, there is a 16 to 20% risk of having micrometastasis. So it is better that you stay one step ahead of cancer and try to treat them with one of the adjuvant modalities. Now let us discuss those. So with radiotherapy, the cumulative the evidence have shown that there's a prolonged time to recurrence if you perform radiotherapy after pelvic lymph node dissection, and there's also better median overall survival 12 versus 8 months. But these two are when in the absence of external extension. For chemotherapy, again, it has shown that it improves median overall survival. When adjuvant chemotherapy is given, it is about 22 months versus when it is not given, it is about 10 months. But again, external extension, there is some controversy whether only chemotherapy helps or not. We know that there is this adjuvant chemotherapy has a better, longer recurrence survival as compared to neoadjuvant chemotherapy. But in terms of external extension, chemotherapy alone may not be as beneficial. So, in terms of external extension, what works well is the chemoradiotherapy, which provides that's a combination of both chemotherapy as well as radiotherapy, which provides a benefit in entry disease with external extension. Now, with enlarged pelvic nodes, I think which we most commonly see, the prognosis is further poor. So when all we discuss right now is when you don't have lymph nodes, pelvic nodes, and you're trying to go step ahead when you have some predictors on the inguinal node. But when you have enlarged nodes on imaging, chemotherapy is the standard of care. If the patient is not fit for chemotherapy, you add chemotherapy and radiotherapy only to circumvent the problems. Otherwise, chemotherapy followed by salvage surgery offers some benefit, but although the evidence is not very robust to answer the overall survival. So the practical tips, I would say, stay a step ahead of cancer. In fact, we had a patient where we started with sentinel node, then we went ahead with modified node, then we went ahead with radical inguinal dissection, then a pelvic node dissection. So it is better in penile cancer. It's largely a surgical disease. So we should stay a step ahead of cancer and try to take care of the micro metastatic spread or risk, which is there, which is largely guided by the penile lesion. So I would, as Dr. Ayres very rightly pointed out, as it is as important to do a sentinel node biopsy, I think pelvic node dissection also becomes an important when you have more than 2 nodes in inguinal bay. Thank you very much, Keval, for the opportunity.
Thank you, sir. Thank you for brilliant overview of how we should manage. I think the justice to the topic has been done. I have few questions, sir. Firstly, okay, so most of the times what happens in our institutes is that, you know, many of the pelvic lymph nodes may, the adequacy, because giving a practical number, more than 2 positive number, leads to a very fallacy that if the lymph node dissection is inadequate. So how do we define that? Because most of the times, if only 2 lymph nodes or 3 lymph nodes, inguinal lymph nodes has been dissected and still only 1 is positive, how should we proceed that? You can take that question, sir, and then I'll also like to ask UK experience from Dr. Ayres.
Yeah, I think Keval, this thing should not happen. The problem could be that either in the process of trying to preserve the flaps and trying to achieve a node dissection, you remain very few nodes. 1 or 2 nodes is not acceptable. It should be at least more than 10 nodes. Although to answer whether adequate node dissection has been done, the average number of nodes on inguinal should be 15. So you must actually sit with your pathologist and try to dig deep. In fact, in our institute, there was a problem at least a decade back where we used to get only 5 or 6 nodes after a proper radical node dissection. All we did was sat with our pathologist and went and explained them the importance of it, and then they started looking more into it, and now the yield is good. So one is pathology, and other is you must ensure that you did a good job. So there is no shortcut to it. I will say it is not acceptable that if you have 1 or 2 nodes, it just means that one has not done either a surgically right job or a pathologist has not done a right job. Something is missing there.
Okay, that's accepted, sir. But Dr. Ayres, what I wanted to highlight here is that is only the number, should we stick to the number, or there is something beyond number? Because sometimes there's a ratio of like either there are 10 lymph nodes and the only 1 is positive, and there are 5 lymph nodes and 3 are positive. So that changes the prognosis. So how do you see that, sir?
Yeah, so the first thing I would say is with respect to pelvic node positivity, the thing that worries me most in the groin is extracapsular spread. And if you've got extracapsular spread in the groin, you've got to assume the pelvic nodes are positive and treat them with radiotherapy if the patient isn't a surgical candidate. And if they are a surgical candidate, then clearly get on and dissect them. And there's about a 40% plus chance of finding pelvic node positivity, even if CT scan is normal with extracapsular spread. So that's a big thing. I agree. The ratio is a challenging one, and people have looked at this, and the Dutch in particular, Amsterdam data have looked at this, and they have talked about the ratio, and the higher the ratio, they've called it lymph node density and things like that. The higher the ratio, the more likelihood pelvic nodes are positive. But I would agree with your previous speaker. There's no excuse for not doing a proper inguinal lymph node dissection, and that needs to be a template, and you need to follow the anatomical markings. If you're not getting many nodes when you do, and you're following the proper anatomical markings, then as you say, you need to talk to your pathologist, because they may not be finding all the nodes. And the only other situations where I've found very few nodes in the groin is when it's a huge nodal mass. So sometimes you get a huge nodal mass of 9 or 10 centimeters and you clear the whole groin and they only find 1 or 2 additional nodes. Well, that's because everything has coalesced into this mass. Collapsed. And of course, in that situation, you're going to be going after the pelvic nodes. You've probably already given them some neoadjuvant chemo. But there is some data out there on lymph node density, although I must admit, I base most of my pelvic node dissections on pure numbers and extracapsular spread.
So Dr. Ravi, one more question to you, because most of the times we talk about extranodal extension or extracapsular extension of inguinal lymph nodes. we often miss or we often don't see what is the external extension of pelvic lymph nodes. Suppose if there is external extension of pelvic lymph nodes, what additional therapy or what additional precautions do we want to do for that patients?
Yeah, the if there is ENE in pelvic nodes, we have already missed the bus. So that's for sure. We need to prognosticate it in that way. But yes, obviously, the same way as we do for the if you have an ENE on pelvic node, mostly they would have actually received some kind of neoadjuvant therapy. You would supplement them with adjuvant radiotherapy as well as chemotherapy. Even despite that, you might not have a very good prognosis. Those fibril surveillance will drop down to anywhere between 15 to 20%, even lesser if you have an ENE on. But yes, they need to be treated with both adjuvant chemo as well as radiotherapy. So both to the groin as well as to the pelvis.
Okay.
It would mostly go in the form of an MDT kind of discussion where you will have to look into the patient's general condition and his ability to undergo any kind of treatment. So, but yes, they need to be more aggressive.
So thank you, sir. Thank you for your enlightening talk. Now we move on to our next speaker, and our next speaker again is an international speaker. I hope Dr. Philippe Speiss is there because he has already sent me his recorded video in case he is not able to join. So I think he's not joined. And Dr. Philippe is a very well-known figure and president of the Society of Rare Genitourinary Tumors. He's a genitourinary oncologist and assistant chief of surgical services at the Moffitt Cancer Center. He also serves as senior member of Department of Geo-Oncology and Department of Tumor Biology and medical director of Virtual Health at Moffitt Cancer Center. He serves as vice chair of the NCCN panel on bladder and penile cancer. So with that, let me
Well, first of all, thank you very much for the opportunity to participate in this. Well, first of all, thank you very much for the opportunity to participate in this webinar and symposium dedicated to penile cancer. Congratulations, first of all, to my good friends and colleagues for putting this together. I think it's important to have focused educational opportunities to highlight, I would say, advances in the care of penile cancer. And as someone who's dedicated most of his clinical and surgical areas focused to penile cancer, I'm glad to see many thought leaders in this space are really being developed in India and many parts of the world. So the topic I was asked to speak on is sentinel lymph node biopsy for penile cancer, how to develop this technique at our institution. In terms of this technique, I will say that this is something which has evolved quite a lot in the literature related from some of the earlier, I would say, approaches, and I'll sort of give you a little bit of a historical perspective in that regard. So in terms of my disclosures, I don't have any financial disclosures. I do serve as the vice chair of the NCCN committee in bladder and penile cancer, as the president of the Global Society of Rare Genitourinary Tumors. So, this technique is one that I really had the privilege to work with a good friend, colleague, and mentor, Curtis Pettaway, on back many, many years ago, dating myself here, over 17 years ago when I was a fellow back at MD Anderson. We had really looked at the, I would say, clinical acumen and accuracy of this technique versus to gold standard inguinal lymph node dissection. So this is a prospective study that was conducted in patients that underwent a pre-operative lymph scintigraphy using a combination of blue dye and technetium, along with on that ipsilateral side an inguinal lymph node dissection being the gold standard. Among patients with penile cancer, high risk featured, but no palpable adenopathy as noted on physical examination and on radiographic studies. 31 patients were part of this study. Again, no patients had palpable or non-suspicious nodes. All patients underwent a superficial lymph node dissection, and the necessity for a deep was determined based on frozen sections. Overall, the sensitivity of preoperative lymphoscintigraphy was 86%. However, there was 2 false negatives representing the sensitivity per side of about 71%. Really, I think there have been some very, really excellent refinements of this approach. I would say many of our colleagues in Europe have really contributed to this. Colleagues in London. This is a nice article that was published back in 2008, looking and highlighting that in patients who have falls, really who are going to undergo dynamic lymph node biopsy in the setting of clinically no negative disease, obtaining a fine needle aspiration of any suspicious nodes is critical, because we do know that patients with lymph node metastasis may have occlusion of their lymphatic channels, which could result in false negatives. So when this technique of biopsying and obtaining a needle aspirate of those suspicious nodes was completed, the false negative rate was dramatically decreased to 11% in this specific study. You know, the colleagues and I was appreciated to be participating in this global, I would say, guideline committee of colleagues in Europe and in North America, developing both EUA, EAU, and ASCO guidelines in penile cancer back in 2023. These are guidelines really representing best level evidence and how people practice in an evidence-based fashion across the globe, and specifically looking at dynamic sentinel lymph node guidelines and what does it all they tell us. So, and these guidelines were published in European Urology back in 2023, and they were also presented at the EAU in Milan back in 23. Really, if you see here, it does highlight that as a surgical staging tool, DSNB, again, the appropriate clinical setting is an excellent tool and is strongly recommended. Now, if this technique is not readily available at your institution, consideration of an open or minimally invasive lymph node dissection clearly is appreciated and is reasonable. If there are no palpable nodes on physical examination, offering surgical lymph node staging using this technique, again, for patients with T1B or higher, is critically something which is advocated for. Again, a strong recommendation. What does the NCCN guidelines and the 2023-2024 guidelines really sort of highlight very similar features in patients who have intermediate to high-risk features defined by T1B or higher, again, in the setting of non-palpable disease, inguinal lymph node dissection, or dynamic sentinel lymph node biopsy are both accepted and reasonable therapeutic approaches in patients. I will tell you the adoption of dynamic sentinel lymph node biopsy in North America has been somewhat slower than it's been in many parts of Europe, and for the simple reason that not many centers have expertise in this technique. And we did publish this systematic review looking at dynamic sentinel lymph node biopsy as part of the minimally invasive surgical approaches for staging in the lymph nodes. And really, the guidelines in this article really highlights that in the systematic review, reviewed 41 studies. For the most part, these were descriptive study. Dynamic sentinel lymph node biopsy with ultrasound and not needle aspiration really has a low false negative rate of anywhere from about 3.5% to 22%. Complication rates is dramatically less than it is for inguinal lymph node dissection, whether that be performed using an open or minimally invasive approach. And of all the surgical staging options, DSNB with inguinal ultrasound fine needle aspiration clearly has the lowest complication rate, a very high diagnostic accuracy. So therefore, it's advocated particular at high volume centers with the expertise, and I would say the volume, because there is clearly a operator dependent, and I would say a learning curve to this technique, much to what we do in the operating room. So how do I do it specifically at my institution? I will tell you that this is a technique which we've been really completed in a very selective fashion over about 10 years, but really in 2023, when the guidelines really took a stronger position related to the preference to this, is something we've invested time, effort, and I would say resources to. So again, in very selected patients with T1B, grade or high-grade tumors or greater in the setting of non-palpable disease, patients must have a negative physical examination, negative CT or MRI with contrast if no contraindications. If there's a suspicious node, obviously low threshold for an image-guided biopsy. And I would tell you that when we embarked on this technique, I completed these surgeries with my colleagues in the melanoma program, completed about 5 cases, really to develop this technique, make sure that our clinical accuracy and I would say comfort with this technique was quite accurate prior to offering it to patients. So this is a schematic of how we do this. So again, in patients who ultimately meet that criteria, they are subsequently scheduled for this procedure. There needs to be a commitment to performing diligent surveillance. Usually ultrasound is quite sufficient. On day of the procedure, we apply usually a topical lidocaine cream to the area where the injection is completed with technetium. This is done, we subsequently do a SPECT CT. This is a technique we've adopted for melanoma. It provides excellent, I would say, anatomical localization of these nodes. Oftentimes they are marked by our colleagues in interventional nuclear medicine. And on the day of the procedure, we confirm that there is in fact activity in those nodes in the preoperative bullet bay. Thereafter, I bring the patient to the operating room. We used to use actually a combination of blue dye with technetium. I will tell you, in the last 5 cases, we have evolved to using IGC, and really an excellent technique. I tell you that intraoperatively, we are able to pick up really small volume disease, and it's really been a game changer. And oftentimes, we're looking for nodes that have activity at least 10 times higher than backgrounds. Usually the backgrounds should be 100 or less in terms of overall counts. And then obviously, as I mentioned, we typically will take patients on antibiotics for a period of 3 to 5 days. We will reassess the patients typically by telemedicine about 2 weeks. If they're positive, we try to recruit them to the IMPACT trial. And we do follow, as I mentioned, patients with inguinal ultrasound every 3 months for 12 to 18 months. These are SPECT CT images, as you see, highly very accurate and very sensitive for picking up these nodes of activity, which we are able to localize. This is what patients look like preoperatively, obviously able to pinpoint those specific nodes. And then really, again, confirming high activity. This is the node which had activity of 750 following removal with background. So this, in this specific case, was 50 to 75. So again, 10 times higher counts were confirmed. This is our early experience. Since then, we've performed an additional 50. As you see here, we picked up at this point 2 positive nodes, and these patients have been on IMPACT. These surgical procedures typically take an hour or an hour and a half or less. We have not had any complications. I did have one patient with a recently symptomatic lymphocyte treated by drain. The patient had accompanying significant morbid obesity, which probably contributed to this. But I will tell you, in appropriate selected patients, I will tell you the ones to avoid early on are patients with high BMI. Oftentimes, those incisions you end up doing are typically over 5 centimeters. Obviously, they're at risk of higher risk of wound infections. With that being said, we now complete those in all patients, including patients with high BMI, but probably in the first 10 to 15 would probably be those patients that I would avoid. And really, it really has been a very paradigm-changing treatment approach. I will tell you next steps is we're trying to standardize this technique among high-volume centers across the globe. These are efforts ongoing between several European centers and our institution, as well as MD Anderson. Hopefully, we will standardize this approach in terms of dyes, in terms of typical methods by which this is completed, really to try to provide a more robust, I would say, scientific methodology, how we complete this with the highest clinical accuracy for our patients. Again, I thank you very much for your attention, your interest. Congratulations to Dr. Kashiv and all the respective colleagues for organizing a sensational meeting. And I will be looking forward to being in India, the SIU, in a couple of weeks. Hoping to meet several of you there, as well as visiting my good friend, Dr. Gagan Prakash, at Tata Memorial in late October. So thanks again for your attention. And, hopefully, I will be able to answer any questions you have at the time of your conference. Thank you.
Okay. So now we have our very senior colleague here, Dr. Ganesh Bakshi. Sir, are you there? Dr. Ganesh Bakshi, sir.
Yes, sir. Keval, I am there. They had
Yes,
put
sir.
me mute actually, so.
Okay, sir. So as you watch this presentation, sir, if you look at our Indian scenario, what do you think? What should be the learning curve for establishing this? Like, if an institute wants to start this program, how much caseload should they have for starting it?
How much caseload? Okay. So you need to buy a couple of instruments. I mean, hearing about all the things which we have gone right from 7:30 p.m. today, one thing is very clear, or looks clear rather, that it is best that these things are handled by, the first talk which Dr. Ayres gave, by a specialist center or a high volume center or a specialist surgeon. So it would be okay to gather all the equipment as like Dr. Ravi gave his talk at that place, or Tata Memorial Hospital, or what Dr. Anand Raja is doing in India. So I think you should have a good caseload, and that turns out into a better practice or better surgery and better outcome. Adding these gadgets, doing these procedures will do even better. Because DSNB itself is evolved to minimize the complications arising from an unnecessary lymph node dissection. Complete.
Yes, sir. Sir, as we know that we are using radioactive dyes here. So do you think we need some additional permissions for that to procure?
I don't think so, because at institutions, I don't know about the nursing home practice or very small hospitals, but big institutions, I don't think find it difficult to get these facilities on board. I think nowadays in more than one discipline, these kind of dyes are used in more than one cancer, if I say so. So having these facilities in a cancer hospital, I don't think is a difficult thing.
Okay. Yes, Dr. Ben.
And specialist where super specialty and cancer treatments are available, I think these machines, these equipment should be on board.
Yes, sir. Yes, sir. Got it. Got the point. Now, I'll like to ask Dr. Ben, since you have a huge experience, you have a huge load, sir, what according to you do you think that should be the ideal case before standardizing the technique or before anyone performs? Because as Dr. Spiess told that this is a very operator dependent technique, how much cases should one be acquainted with before he starts doing it independently at his institute?
The learning curve.
Yes, the learning curve.
So, I mean, I think it's important that this is a technique that you need to learn and you do need to be mentored at. I agree. I agree that you want to do everything that you can to help yourself. So clearly having a really good relationship with your nuclear medicine department to make sure they're injecting the right dose in the right place and all that, and having that good relationship. So it's not just mentorship of the surgeon, it's mentorship of your nuclear medicine department with other nuclear medicine departments that are doing that part. Because actually I've talked to the Americans, I've talked to Dr. Spiess, and they've had a few groins that haven't worked. And the reason we think they haven't worked is that actually the nanocolloid that we use in the UK is not FDA approved, and our one has smaller particles than the one that is FDA approved. So we think that sometimes the bigger particles probably don't actually go through the lymphatics into the nodes, and that might explain some of the false negative rates that they see in America. Clearly, I don't know what nanocolloids are licensed in India. Sorry for my ignorance there, but I found that as an interesting, thing that was stopping things was FDA approval of the nanocolloids that we use in the UK. So I think all these things need to be looked at. It's not just surgical, it's the radiology. When it comes to the surgical case, as we said, whilst I don't rely on SPECT CT, I think when you're starting off, SPECT CT is really important because it will tell you where that node is anatomically. And you get a lot of background calc come from pelvic nodes. So it's really important that you understand whether that node that you're still getting count from is a pelvic node or not, and your SPECT CT will tell you that. I would then start off with slim patients, okay? Sentinel nodes in big, large patients with high BMI is challenging. When I've got new consultants here at St. George's or trainees, those are not the cases that they do. Those are the cases that I do or they help me with and I teach on. The cases that they do independently with me supervising and mentoring them will be patients that are slimmer. So you want a BMI of less than 30, definitely. But in terms of number of cases, I think if you follow principles and understand the anatomy, I think you can learn the technique reasonably quickly. You know, it is, if you're, particularly if you're doing groin dissections already and know the anatomy from your superficial or complete groin dissections, I think it is a transferable skill. So I wouldn't like to put a number on it. I think it's important to pick the right cases. We've looked at our false negatives here at St. George's, and none of them have appeared within a learning curve. They appear sporadically. And the vast majority of them result in recurrent disease within 6 months. And a lot of those patients, unfortunately, do then not respond to adjuvant treatment and they die. And I think that a high proportion of our false negatives, unfortunately, reflect poor tumor biology. So I don't think we've necessarily missed a node. I think this was cancer that was going to recur quickly in the groin, perhaps some cells hiding in a lymphatic channel rather than in a node that have become a soft tissue met, because often when you go back in, it's not a discrete node, it's a soft tissue metastasis within the groin. And so I think a lot of our failures, our false negatives, are actually more representative of poor tumor biology than poor technique. But I get it that there will be some cases where if you're not experienced and you've not got a mentor, clearly technique could come in. But I think radiological technique is just as important as surgical technique.
Yeah, so very well made point, sir. Dr. Anand Raja is here. Dr. Anand Raja.
Yes, I'm here, Keval, I'm here.
Yeah, you were just mentioning something about the small size of the colloid. So what was it, sir? Please elaborate.
So what happens is that we are very used to, very similar to what was already mentioned about standardization. So what we originally did, in addition to the question that you did, is first before we standardized the technique, we actually used 20 groins, 20 patients, 40 groins. We did the sentinel node and then followed it up with a staging inguinal lymphadenectomy and kind of, got our technique in place, made sure that, we are not missing the sentinel node, so on and so forth. So it took us about 40 groins before we could finally say that, we are skipping the lymphadenectomy and just doing the sentinel node. We published that in the Indian Journal of Urology. We also kind of, before that period, kind of experimented with various isotopes. Yeah, we experimented with the filtered technetium sulfur colloid, the unfiltered technetium colloid, and the nanocol. The problem with the nanocol is that the particle size is so small, as Dr. Ben had actually said, that it not only goes to the first echelon node, which is the sentinel node, but because it's so small, it very rapidly travels even into the second and the third echelon nodes. So what happens is that when you do the sentinel node, instead of getting the first echelon, everything, is hot. So you get more number of nodes you get. Instead of getting those 2 or 3 nodes, you end up getting 6 or 7 nodes, and you end up doing more lymphadenectomy. Removing more number of nodes, which only contributes to morbidity without adding value. So we gave up on the nanocol. We only use filtered technetium colloid. That's been our experience.
Yeah. Okay. So with that, like I think we'll move on to the next session of our program. That would be case video presentations. So for that, I first invite Dr. Amitabh Singh. Dr. Amitabh, he's a consultant uro-oncologist at the Rajiv Gandhi Cancer Institute. He'll be presenting a video on open inguinal lymph node dissection because for the benefit of the residents. Yes, over to you, Dr. Amitabh.
Yeah, can you hear me?
Yes.
Okay, so good evening, everyone. Coming to this video, so we all know that open inguinal lymph node dissection is gold standard, and it has got the value for therapeutic purpose, not for diagnostic or staging purpose, because now dynamic sentinel lymph node biopsy is coming in a very big way, which decreases morbidity also. But we all should know what are the best good technique and the ideal way to do open inguinal lymph node dissection, as the complication could be higher up to like 50 to 60%, combining minor and major complications. But if you are having a very good surgical anatomy and techniques of developing the flap, then we can decrease the morbidity of the flap necrosis, skin age necrosis, and some other complications like lymphocyl also, and skin infection or cellulitis in post-op. So just I'll be starting with this video. So coming first to the position of this patient. So we all make the frog leg position and we extend the hip also. Frog leg, basically, it does open the medial part of the thigh, and extension at the hip makes the anterior abdominal wall in line with the thigh. So it helps in opening the upper flap also. By frog leg, actually, what we do, it makes the adductor muscles taut, so we can feel it very easily, and we make the femoral triangle markings. So this is a standard marking, SIS, pubic tubercle. This is a classical Dressler quadrangle. We always mark femoral artery. And this is fossa ovalis marking, which is roughly around 4 centimeter lateral and 4 centimeter down below, where the saphenous vein goes into the fossa ovalis and merges with the femoral vein. So it is better to mark all these landmarks on the thigh. It gives better idea where are you dissecting and what is like your limit of the dissection. So it just decreases the post-op complications also and having a better orientation while operating. So nowadays, it is not very mandatory to include the complete dissection into the Dressler triangle. We can decrease your resection area also. So this is, I'm telling about the skin incision. So what I do, I mark the incision, that is a horizontal classical incision, 1 finger breadth below inguinal crease. And for classical inguinal block dissection, you can take 8 to 10 centimeter. You can decrease also in modified inguinal lymph node dissection. And why horizontal? Because all the vascularity is coming horizontally in the thigh, so it reduces the chances of skin flap necrosis. But when you need to do pelvic lymph node dissection along with the iliac node inguinal block dissection, then you can take a lasius incision also. Here I am giving the skin incision, cutting first skin, then dermis, and after that I will get into the superficial fatty layer, which you can call as a camphorous layer also. After dissecting the fatty layer, you will see this membranous layer. You probably you can appreciate very well this membranous layer, very thin membranous layer, which we call it as a scarpa's fascia. So this landmark is very important to identify, because once you identify this scarpa's fascia and you limit your dissection below the scarpa's fascia, you significantly reduce your skin necrosis. So use the blade, do sharp dissection and try to identify the scarpa's fascia. Once you identify the scarpa's fascia, use skin hook retractor or cat's paw. If you don't have all these instruments, you can use Ellis forceps, but try to hold only fascia, not the skin. Otherwise, it will lead to skin age necrosis. And here I am doing upper flap dissection. So it is very important to understand that this scarpa's fascia is very prominent on the upper flap. You can see very well this membranous layer. And I am dissecting all the fibrofatty tissue from this scarpa's fascia down below. After completing upper flap, now I will go for the lower flap. Compared to the upper flap, relatively in the lower flap, the scarpa's fascia is not very well delineated. So while dissecting the lower flap, you need to palpate the flap also just to see the thickness, whether you are making very thin or very thick. But in most of the patient, you can see the scarpa's fascia also in lower flap. But it is ideally advisable to palpate the flap also just to see the thickness. Otherwise, you will get the necrosis of the lower flap. After mobilizing upper and lower flap, just I am putting my finger and showing the extent of mobilization of the upper flap and lower flap. So it is matching the Dressler quadrangle. So in the lower flap, it is not mandatory to go up to the lower margin of the Dressler quadrangle. After mobilization, I will try to identify the saphenous vein, great saphenous vein, which is lying into the lower medial part of this whole boundary. And it is mainly found over the adductor longus muscle. Once you found that saphenous vein into the fibrofatty tissue, you can extend your lower part of the dissection. You will always found this anterior vein of thigh also, which you can call as a accessory saphenous vein also, which is found laterally to the saphenous vein always. So once you have mobilized this lower fibrofatty lymphatic tissue, then you can extend your dissection laterally over the scarpa, this fascia lata. So here just I am mimicking the superficial inguinal block dissection where I am not opening the fascia lata. So this is saphenous vein, this is saphenofemoral junction. So now what is happening actually, classically we have been taught that all these lymph nodes, they are in the horizontal and they are in the T-shape, horizontal chain and the vertical chain. But now we know they have been divided into the 5 areas like superomedial, superolateral, inferior-medial, infralateral, and the center quadrant. So this actually this part of the dissection is I am dissecting all the fibrofatty lymphatic tissue from the fascia lata laterally. You can see the thigh muscles wrapped into the fascia lata down below and lifting the whole lymphatic packet from the fascia lata without incising the fascia lata. So what happens laterally, you don't find any significant vein or any critical structure. So you can be very confident while dissecting or lifting all these lymphatic packet laterally. Once you are complete, you have completed your lower part and the lateral part of the lymphatic dissection, you can go up to the fossa ovalis down below. Now here you can appreciate the saphenous vein is going down below. Now here I'm just lifting all these lymphatic tissue from the fascia lata and you will see the fossa ovalis, the lower border or the lower margin of the fossa ovalis. Here I'm applying the metallic clip on the arterial branch which is coming from the femoral artery, and the branches of this main artery will accompany all the tributaries of the great saphenous vein. This is the lower border of the fossa ovalis, which is a defect in the fascia lata, and this is the main saphenous vein which is going into the fossa ovalis. So because I am doing this superficial inguinal block dissection right now, so I have divided this whole dissection into the superficial and the deep dissection. After taking the lymph node from the infromedial and infralateral part and the central, I'll be moving my focus on the upper part of the dissection where the sentinel lymph node is most probably is present in most of the cases. So you can see all the tributaries like lateral circumflex iliac, superficial epigastric, and this superficial external pudendal. I am dissecting all the lymphatic tissue while preserving all these tributaries of the great saphenous vein also. So after taking out the lymph node and finishing the superficial inguinal block dissection, so you will see this picture. Preserve all these saphenous, accessory saphenous along with the tributary. Once superficial inguinal block dissection is done, I'll be moving towards the deep inguinal block dissection, where I will incise the fascia lata at the femoral triangle, but I will not go lateral to the femoral artery to prevent the injury to femoral nerves. So you can see this defect. After incising the fascia lata over this femoral triangle, I'll be just dissecting the femoral artery, separating all the lymphatic tissue from the femoral artery, femoral vein, medializing the tissue. So you can very well appreciate this femoral artery and femoral vein. This is the femoral artery, this is femoral vein. So just dissecting all the lymphatic tissue from the vessels. And the fascia. So now once I have reached to this lower border, I will tie them with a silk just to prevent the lymphoria. And all these great saphenous and the tributaries has already been retracted with this Journey's retractor medially, just to expose the field. Once these lymphatics are tied with the silk, I will dissect them and I will try to go up medial to these saphenous vein up to the deep inguinal vein to take out the lymph node of the ideally, we usually get 1 to 2 lymph nodes in the deep pocket. Now I'll just, I'm separating this arterial branch. I'll make it sure. I'll apply another metallic clip so that it should not bleed in the post-operative period. Dissecting all the lymphatic tissue medial to this femoral vessel. And I will just trace all these lymphatic tissue up to the deep inguinal ring, medial to this femoral vein. And at the same time, I will try to preserve all the tributaries of the great saphenous vein. As Dr. Benjamin has correctly mentioned that it is very important to preserve all these lymphatics if we are doing the superficial inguinal block dissection just for a staging purpose, because they all reduce the complication. And in most of the cases, I have seen that we can preserve all these lymphatics, whether you are doing a minimal invasive technique like laparoscopic or robotic technique or open inguinal block dissection. In most of the cases, you can preserve them until unless you are having a very large lymph node, bulky lymph node, desmoplastic with desmoplastic reaction. So once I have mobilized all these lymphatics medial to the femoral vein, I will try to reach them or dissect them up to the deep inguinal drain. And after taking them, I will finish my superficial as well as the deep inguinal block dissection. Because I have recorded this video with iPhone, so that's why it's moving. So sorry for this. After finishing, so because Dr. Keval has requested just to mention how to do sartorius rotation flap also. Otherwise, it's not always mandatory to have a sartorius flap over the femoral artery because it increases the complication also like post-op pain, increase in lymphoria also. So just mobilize this sartorius muscle from the lateral border. After mobilizing the sartorius, divide the head of sartorius muscle, which is attached to the ASIS. So very important point is that all these, actually this muscle is having a segmental vascularity. So we need to understand this point. Now you can see this branch, which is coming from the medial border of the sartorius muscle. So all these muscles, they are very thin and they are coming from the medial border of the sartorius muscle, and they supply the segment of this sartorius muscle. So we need to preserve all these segmental arterial supply of the sartorius. Otherwise, the muscle will get necrosed and there won't be any benefit of doing sartorius flap, a rotation flap. So just after mobilizing the sartorius, I have covered the femoral artery and vein with the sartorius. Now you can see the sartorius muscle, and not but the least, always refresh the part of this skin flap, upper flap also and the lower flap also. And while this incising or refreshing the flap, if you see all these capillary oozers, then you can be very much confident that there is no vascularity issue associated with this flap, and you won't have any flap necrosis or skin age necrosis in the post-operative period. Close the flap in 2 layers, inner layer and outer layer, put the drain. So this is the final specimen. And on frozen analysis, we found almost 15 nodes in this superficial and deep inguinal dissection. So thanks for your patience hearing. If there is any question, then I would love to answer them. And thanks for organizer also, chair and convener, to giving me this opportunity. Thank you, sir.
Thank you, Dr. Amitabh. I think it was a very informative video, especially for all the residents who are just learning all the techniques of open inguinal lymphadenopathy. One quick question and we move to the next video. So can we approach pelvic lymph nodes through the stem incision?
Horizontal incision?
Or maybe through this incision?
No. If you are planning for pelvic lymph node dissection, then either you have to give a separate midline infraumbilical incision or Lazius incision. With this horizontal incision, some surgeons, they have described 2 horizontal parallel incision, one at the abdomen, one at the thigh. So through that you can approach, but with this single horizontal incision, you can't approach pelvic lymph node dissection.
Where exactly do you find the lymph node of Tocket?
Okay, so sometimes what happens in most of the cases, this node is found only in the pelvis. So in the inguinal area, you won't find that node. In this almost 7 to 8 year, I have done deep node. I didn't find more than 1 or 2 node after doing deep node. Most of the time, I did get only fibrofatty tissue. That's it.
Okay. So with that, now we just running short of time. We move on to our next video. I invite Dr. Thank you, Dr. Amitabh. I invite Dr. Tarun Jindal, our next speaker, who is a consultant on uro-oncologist at the Apollo Hospitals, Calcutta. Over to you, Dr. Tarun.
Yeah. Thank you, Dr. Keval. I believe my slides are visible. Let me go on the slide share mode. Yeah. Are the slides visible?
Yes.
Okay, right.
Yes.
So thank you, Dr. Keval, and thank you, the organizers, for allowing me to share our experience and about robotic inguinal lymph node dissection by lateral approach. I believe the gold standard and an extremely important aspect of the groin dissection remains open surgery, and Dr. Amitabh has wonderfully discussed that. And I think it's extremely important, and it's an exam question as well as a viva voce question for all the residents. So we must be absolutely abreast with the open approach, and for the newer advances, robotic approach can also come out as the discussion as a full question. So we'll be discussing as to how to go ahead, and the steps of robotic are exactly similar to the steps of the laparoscopic approach. So both can be understood by this presentation. So groin dissection, we have already discussed, is a surgery which is meant in the management of carcinoma penis, vulva, lower limb melanomas, and scrotal tumors. It's a morbid procedure, and in best of the best hands, the chances of complications range from 25 to 30%. And the most dreaded complications are like wound dehiscence, flap necrosis, seroma, hematoma, and edema. And anybody who has been a part of open surgery will very well remember these kind of wounds. These take weeks or even months together to heal. The patient's lives are miserable, they get secondarily infected, and they take a very, very long time to recuperate from this particular open procedure. So the laparoscopy as well as robotic groin dissections have been described to decrease the morbidity which is associated with the open surgery. And this is one of our papers which we published. It's a multicentric trial where Dr. Amitabh is there from Rajiv Gandhi, us, and Dr. Raghunath from Bangalore. We all collated the data, and we found that the robotic assisted approach is definitely more feasible, more convenient for patients. Early discharges are possible. The blood loss is lesser. The flap necrosis is absolutely not found. The lymph node yield and the cancer controls are also equivalent. So probably henceforth, this is the way forward, and open surgery will remain the gold standard, but people are supposed to be, we as surgeons are supposed to be less morbid, and robotic and laparoscopic approaches are probably the way forward in the management of groins. So conventional robotic whale, the problems are once we are doing a robotic whale, the space between the ports is lesser. So there is external arm clashing, and the camera also tends to hit the knee, because once you are approaching the groin, you put your camera like this and the camera starts hitting the knee. Along with that, because it's a fibrovascular space, so you do not have specific landmarks. It's like entering into a retroperitoneum, and unless you have landmarks, the surgery is extremely difficult. To identify the saphenous vein in a conventional approach is a taxing procedure as compared to a lateral approach. So that is the reason why lateral approach was described. The approach is more ergonomic. We have the entire lateral aspect of thigh to ourselves, so we have more space. The instrument clashes is extremely low. The blood loss is low, and the identification of landmarks is extremely easy. The most important landmark, saphenous vein, within 10 minutes of surgery, you are able to identify that saphenous vein, and that will lead you to all the important vascular structures. So we started doing the lateral whale in the year 2018, and in 2020, we published the first international publication describing the laparoscopic and robotic video endoscopic by lateral approach. So initially we started with the frog leg position because we also graduated from an open approach, but then we found that frog leg position is not required. You can just put the leg straight. To dissect the space, you can use a preformed PDB balloon, or you can just use a gauze balloon, which is a very simple contraption. It's hardly 12 rupees, and you can have equivalent space formation as compared to a PDB balloon, which is a very costly contraption. So you give an incision, do the finger dissection, and where the space we enter in is this. So we tend to we identify the fascia lata. We tend to put all the fibrovascular tissue, the fibrofatty tissue above, so that we keep on dissecting over the fascia lata. We identify the vascular structures, and then in the last step, we bring down the lymphatic packet. So this is how we create the space. You can inflate the balloon with air, or you can inflate the balloon with saline. You can go up to 250 or 300 cc's with just glove finger. So this is the camera position of the lateral whale. So I will move towards the video presentation. On the bottom of the screen, you can see that this is the sartorius, and now we are moving towards the adductor longus. Any small perforators, you can just use bipolar, or you can use a ligashore. But now you can see that we are actually bearing the muscle. We should not bear the muscle. So we are correcting the plane, and the saphenous vein was visible. So this is just 10 minutes into surgery that you are able to see the saphenous vein, which is the most important landmark. Any bigger perforators, you can use a ligashore. We do not prefer to use clips because patients are able to palpate them and they tend to confuse them. So you just follow the saphenous vein, and that will lead you to the saphenofemoral junction. So on the base, you can see the pulsations of the femoral artery. You can see the femoral artery there. The femoral vein is also visible. And then you keep on cleaning the area around the saphenous vein and the saphenous artery. So we are going behind and around. And if you want to do a deep lymph nodal clearance, this is the time when you can do it. This goes separately as a deep packet. And as Dr. Amitabh said, we tend to find usually around 1 or 2 lymph nodes in this particular area. If you need to clear the cloacae, then this is the time when you also need to go to the cloacae. But again, cloacae, it's very difficult. I mean, you rarely find cloacae in the groin. So you actually just end up cleaning the area which is medial to the saphenous vein. And if you're lost, you can always ask your assistant to palpate and show you where the inguinal ligament is. And the glistening white structure that you saw was the inguinal ligament. Now we just follow the saphenous vein, and all the tributaries of the SFJ are brought down. As in open surgery, in robotic and laparoscopic, we can preserve the saphenous vein, and we, in majority of our cases, do not sacrifice the saphenous vein, and we have found that this definitely leads to decrease in the lower limb edema. So the tributaries are divided, and then once you are done with the dissection, you turn the scope. So I'm using a 30 up, and you dissect the lymph nodal packet. So that glistening streak of tissue, the fibrovascular tissue which you are seeing in between, that is the layer between the scarpas and the lymphatic tissue. So if you remain in that area, the flap necrosis will never happen. And you can see on your screen, this is the short saphenous, which Dr. Amitabh also showed. This is always found lateral to the greater saphenous vein. So this is how the post-operative wound looks. So the incisions, these are the incisions of the lateral veil. The flaps are hardly ever a problem, but the lymphoria and the formation of lymphocytes, the incidences remain the same. This is the picture of the patient on the 10th post-operative day, and the scars are hardly visible. Thank you. And if there are any questions, I'll be open to answer.
Thank you, Dr. Tarun. Thank you for a very thorough presentation and enlightening the technique. One question, when did you initially we saw that you just had popularized the lateral veil. Then now you have transformed yourself to robotic veil. So for all the people, especially in our country who don't have access, many of them don't have access to a robot. What do you think that is veil equally practicable, or you should do it robotically?
No, it's absolutely practicable. So see, the advantage of veil, specifically the lateral veil, is the vascular dissection. So it is almost like a renal hyoid dissection, and anybody who is trained in laparoscopy, probably pyeloplasties and the renal hyoid dissections are the things which everybody tends to learn. So in a lateral approach, if you saw the video, so what we are doing is basically exactly doing the replication of a venous dissection and the arterial dissection in the hilum. So that is what we are already abreast with. So I would definitely encourage that if you know your nephrectomy, veil is not going to be a problem. And the important landmark is saphenous. So if you are able to identify saphenous, because apart from that, it is all fibrofatty tissue. So once you identify the saphenous, and which it is extremely easy, because in the lateral approach, the entire lateral surface of the vein is visible. It's lying like this. So you would not tend to miss. So it's very easy. And once you identify the saphenous, the rest of the surgery becomes much easier, because you just need to track it. It will lead you to the saphenofemoral junction. The junction will lead you to the femoral vein. The femoral vein will lead you to the artery, and the junction will have the tributaries of saphenous. And dissection is extremely easy, because it's like a hilar dissection.
So well said, point well taken. With Dr. Ben here. Dr. Ben, so what approach do you prefer robotically in your cases? Either it's conventional or lateral?
So I must admit, I've been doing them laparoscopically, or with a laparoscope rather than a robot. We do have robots here, but getting access to them is difficult when my colleagues are doing prostates and kidneys and bladders on them all the time. So my theatre is not a robotic theatre that I normally do my penile cancer case in. So I've been doing them video endoscopically with a laparoscope, and I've done the standard approach there. But I agree, you find the saphenous vein, and once you find that saphenous vein, it makes the surgery easier, because you've got an important landmark that you can follow down to the vessels in the femoral vessels that are clearly the sort of more challenging part of the surgery. I was worried when I first started out that I might break the skin, that the upper bit of the dissection. But actually, when you get the air in there or the carbon dioxide in there, it gives this nice dome shape, and you can clearly see Scarpa's fascia as a really white, sort of glistening structure at that dome. So that wasn't such a concern. The other thing that I was concerned about was doing them in patients that had sentinel nodes, because there would be a lot of scarring. But again, whilst again at the sort of upper bit of the dissection where you're coming onto the sort of the scar where you've dissected down through the groin, that bit's a bit stuck, and you cut through the scar tissue there, which is you're cutting through scar tissue, but you're away from all the vessels and everything. And my concern that there'd be a lot of scarring around the vessels to date hasn't come to light. I found it a very useful technique, but we've been part of a randomized trial here. So we've been randomizing patients with 4 other centers in the UK to open versus minimally invasive groin dissection. So hopefully that will give some randomized data very soon.
We hope to hear from that data very soon, sir. So now with that, we come and end to our video presentation session. Now we move on to a very exciting part of our program, that is critical review of recently published papers. So we have 2 speakers here. First of all, I invite Dr. Amandip Arora, who is Associate Professor at the Tata Memorial Hospital. Amandip, kindly share your screen. Aman? Okay, is
yes,
Anand?
yes.
Okay. Yes, please.
Give me just 1 second.
No issue.
Okay, is my screen seen?
Yes, Aman.
Hello?
It is seen. Yeah, it is seen.
Okay. All right. So, Dr. Keval, thank you so much. And so I was asked to critically review a recently published penile cancer manuscript. And it is not going to be a critical review. It's actually going to be learning from that recent penile cancer manuscript. And we'll see how best we can apply it to our day-to-day clinical practice. This is the manuscript that we're talking about. It's not actually a research paper. It's basically a review article. And it was written in the Urological Clinics of North America, the penile cancer booklet. So this was one of those chapters, Management of Bulky, Inguinal, and Pelvic Lymph Nodes. And Dr. Phil Spiess was one of the co-authors for this paper. So I could not critically review it, but apply this paper to our day-to-day practice. So first of all, what are bulky nodes? So this paper says that inguinal lymph nodes 4 centimeters or greater in size and or fixed lymph nodes are classified as bulky. NCCN also classifies its entire risk treatment management protocols and the algorithms as per non-bulky lymph nodes and bulky lymph nodes, whereas the European Association of Urology still continues to classify them as per management for CN1 groins, CN2 groins, and the CN3 groins. Okay, so when we do have bulky nodes or fixed nodes, do we do an FNAC or biopsy of the inguinal nodal mass to prove that that is cancer, despite having a biopsy from the penile primary? It's not clearly written in guidelines, but in the paper at least, but in the European guidelines say that if there is a palpable or suspicious node at physical examination, we must be obtaining a biopsy to confirm that there are nodal mets before initiating treatment. However, this is for all CN plus disease, so it is applicable even for that one small palpable hard node. But when you have a big conglomerated mass which is fixed to the skin, or you have an ulcerated node, it's really questionable what you're going to gain more by biopsying that inguinal nodal mass when you already have proven diagnosis from your penile primary. Now, when you have clinically involved nodes which are bulky and or fixed, how do you stage the disease? So for staging, we can do these two things. We can either do a contrast enhanced CT scan of the chest plus abdomen plus pelvis, or do an FDG PET CT. At Tata Memorial Hospital, our practice is to do a CECT chest abdo pelvis. That the sensitivity and specificity of FDG PET CT is of the order of 96% and 100%. 100% specificity is almost perfect, right? So PET CT, might slowly become the investigation of choice for staging penile cancers who are node positive over our contrast enhanced CT scan. What do our European guidelines say? So we'll read this sentence. It says in CN plus patients, stage the pelvis and exclude distant mets with an FDG PET CT or a CT of the chest and abdomen with a strong recommendation. So they are stating both, but they're choosing to write the PET scan before the contrast enhanced CT. Okay. For our bulky nodes, this is the surgery that we do. We have seen a very beautiful video shown by Dr. Amitabh as well, and the radical inguinal nodal dissection. These are the boundaries of our template. So classically, the template defined was that inguinal block of nodal tissue that came out, 25 centimeter line, 15 centimeter line. We usually don't do that much. The boundaries are limited by the boundaries of the femoral triangle. So superiorly, we have the inguinal ligament. Inferiorly, we have the apex of the femoral triangle. Laterally, we have the sartorius muscle. Medially, the adductor longus muscle. And the floor is formed by the pectineus and iliopsoas muscles and the femoral vessels. As you can see, this is the picture taken from that paper itself. And this is a beautifully done radical inguinal nodal dissection. Now, inguinal nodal dissection for bulky disease. So there is a much wider dissection that we need to do. Sometimes we need to excise the skin that is involved along with the nodes, and then the patients need myocutaneous flaps, and we need to involve our plastic and reconstructive team colleagues. There is a much higher incidence of complications with these procedures because you are removing more tissue, which leads to more lymphoria, which leads to more lymphedema, which leads to more wound-related complications, infectious and also non-infectious. And also, whenever we have those plastic flap covers coming to cover the defects, there is always a problem with some of those flaps dying. And this always has to be an open surgery, okay? So guidelines clearly recommend that for bulky nodes, for fixed nodes, for nodes that are not mobile, there is absolutely no role of trying to venture in with either a laparoscopic or a robotic veil. So just for example, this is a patient with a bulky node. This is a patient with a fixed node. So the skin over the node is actually involved. And as you can see, along with the node, we had to excise a lot of skin cover. And then that was finally covered up by this flap that was done by our plastic team. So pretty morbid surgery. So what do we do? Do we give neoadjuvant chemotherapy to our patients? So this paper says that neoadjuvant chemotherapy does have a role. And whenever you do want to give neoadjuvant chemotherapy to your patients, it has to be triple agent chemotherapy with TIP, 4 cycles. So paclitaxel, ifosfamide, and cisplatin. So Pacli and 5-FU, the dual agent chemotherapy was a thing of the past. If you want to give neoadjuvant therapy to your patients, it has to be triple agent therapy. But still, even with the neoadjuvant therapy, it is not like our bladder cancer, where most of our patients inguinal lymph node dissection. Our European guidelines say to offer NAC using a cisplatin and taxane-based combination to chemotherapy fit patients who have CN3 disease in preference to upfront surgery. So guidelines are tilting towards offering neoadjuvant chemotherapy to patients who can receive neoadjuvant chemotherapy over first operating them and then giving them adjuvant therapy. So should we never do surgery first in our patients? So when we talk about bulky nodes and fixed nodes, a fixed node means that the node is either fixed to the skin or to underlying structures, and those structures could either be vessels or muscles or bone. But what if, the node has come through the skin? What if the nodal mass is infected and you have some pus pouring out? What if that nodal mass is so infected and so problematic to the patient that it's causing pain? And what if the patient is not fit for receiving TIP? Do you want to give dual agent neoadjuvant chemotherapy? Like, what do you do for this patient? This patient has an infected groin, which is painful. It's probably not an ideal candidate to go ahead and receive chemotherapy, which is going to get his immunity down further and probably lead to sepsis. What about this patient? Ulcerated node, pus pouring out. This patient, right? So these are patients with bulky nodes. These are patients whom we see in our clinics because unfortunately our patients end up coming late to us. But these are not patients that, that get described in guidelines. These are not patients that get described in PERS. These are not patients who are ideal candidates to receive neoadjuvant chemotherapy. And unfortunately, these are also not patients whom, we can probably salvage from the disease. These patients inherently, when they've come to us, they are probably beyond the window where we could do something curatively for these patients. But in these patients, we would do our surgery first. We would do the radical inguinal lymph node dissection first, then probably give them adjuvant chemotherapy, probably add on adjuvant CTRT, and then see how the patients fare. But usually these patients do not do well. So now for the debate of NACT first versus surgery first, NACT first selects out your patients. So patients who do respond to NACT, those 50% with an ORR, these are your good patients, right? And these are the patients in whom doing the surgery is actually helpful. In the remaining 50% patients who have not responded to chemotherapy, you have to end up doing surgery because these patients are still not metastatic. But then that surgery is probably going to end up futile with a very early disease recurrence. But that is what you can offer to that patient at that point of time. If you do the surgery first, it may delay receiving chemotherapy. It may even preclude the patient from receiving chemotherapy at all. If you end up with wound-related complications and the patient never even makes it for chemotherapy. But the objective rate with chemotherapy is only 50%. So what about the other 50%? Do we lose the window of doing curative treatment for them by avoiding surgery first? This is a debate which has not yet been very effectively answered, but we are probably tending towards NACT first for our bulky patients, fixed node patients, and definitely for patients who have involved and enlarged pelvic nodes on our CT or the PET. Do we have an answer to this? So we have an IMPACT trial which is running, which is the International Penile Advanced Cancer Trial. It's an ongoing RCT which aims to accrue in excess of 420 patients, but is probably going to stop at 200 at the end of this year because it's facing difficulties with approval, probably because of the rarity of the disease in the West and the rarity of bulky nodes in the West. It is going to tell us whether we should be doing NACT or upfront surgery for our bulky nodes. And also, it also randomizes patients with bulky nodes within the neoadjuvant template to receive NACT, which is only chemotherapy, or neoadjuvant chemoradiation therapy. Is there any role of immunotherapy, which is so much upcoming in the other cancers that we have? So this is a publication which, this is not a publication, this is just an abstract which was presented in ASCO 2024. The Hercules trial, phase 2 trial of Pembro plus cisplatin in advanced penile cancer. Small study with 37 patients. The response rate is only 40%. So encouraging, but not very encouraging as well. So to summarize the paper and what we've learned from it, bulky or fixed nodes portend poor prognosis. Multimodal treatment is required. Single modality treatment, either with NACT or with a very radical Herculean surgery, is going to end up being futile if you've not added on the other modalities of treatment. NACT first versus surgery first is a debate in patients who can undergo surgery first. In patients who have undergone the surgery, please give them adjuvant CTRT or adjuvant chemotherapy. And probably in a few years' time, the IMPACT trial would have given us some answers to these questions. Thank you.
Thank you, Amandeep. Thank you for agreeing to review this review at the last moment of 6:30. So one question from our own Dr. Bakshi. He asked that if you want to plan adjuvant therapy, then what is the duration of window to start? When
if I want to plan,
if you are planning,
right, so we would want to plan our adjuvant therapy like in any other cancer, as soon as the patient is fit to receive that therapy, which is usually around 2-3 weeks post the surgery. But mostly our patients have not even had the drains out by then. They have some of the other wound-related complications going on, right? So most of our patients can make it to adjuvant therapy probably after a month or so. Yeah.
Is Dr. Ben there?
Most of the patients don't.
Yeah, I'm here.
Sir, do you find such bulky lymph nodes? Because the definition of bulky lymph node may change from place to place, from institute to institute. Because over here, sometimes we find lymph nodes which are hardly 2 to 3 centimeters. They are fixed to the skin. So how do we define them? How do we group them? And how do we manage them? And sometimes we find cases which are like 5-6 centimeters, but they are still mobile. So should we consider what are your views on that?
Yeah, I mean, unfortunately, even in the UK, we do get patients that are not aware of the disease or are frightened of the disease and the stigma associated with it and present late. And we get, probably in my practice, we probably each year see up to about 5 patients who have bulky fixed nodes. If they're fixed to the skin, I call them fixed, and I think by definition, if they fix themselves to the skin, then those have to fall into this bulky category. Mobile nodes, great, but I think, you know, once you're starting above centimeters again, they should come under this bulky category. I think the lesson or the teaching really needs to be that these are not treated by surgery alone. This is multimodality therapy. I think there is some quite convincing evidence now for neoadjuvant chemotherapy or potentially even neoadjuvant chemoradiotherapy. The Dutch from Amsterdam, the NKI, published last year in the Red Journal neoadjuvant chemoradiotherapy, and they argue that it's about as effective as neoadjuvant chemotherapy locally anyway, without the toxicity. But clearly, once you've got bulky nodes, you're worried about micrometastatic disease systemically, aren't you? And that's why my feeling would be that neoadjuvant chemotherapy should be offered to these patients as early as possible. So if surgery is going to delay them getting that chemotherapy, I would try and give them the chemotherapy up front. The only time we would sort of do surgery first and then adjuvant chemotherapy for fixed bulky nodes is if they're too high an infection risk with the fungating nature of the disease, or if the patient is, you know, has such bad symptoms that the main aim is to palliate and then try and offer, you know, more curative type treatment later. But I think the key message is this is multimodal, and if you can get the treatment in neoadjuvant, I would recommend that.
Yes, sir. Thank you very much. One question, one more last question regarding this to Dr. Arora Amandip. How do we assess response to NSCT in skin fixed bulky nodes?
Right. So we do our imaging, either the PET or the CT, after the 4 cycles of chemotherapy. And so we can assess the size of the node, how much of necrosis has happened, and we do our clinical examination. And yeah, that's basically it. So our clinical examination plus the imaging, and that tells us whether the skin has to come out, how much of skin has to come out, do we need the plastic team to be on standby. And yeah, obviously, always look for the skin up and always look for the vessels down. Usually does not go to the muscles and the bones, but the vessels also need to be free. And in all these patients, we are obviously always going to do the pelvic lymph node dissection. So we need to be careful of, the external iliac artery and the vein are all looking clean of those nodes there in the pelvis.
Okay, thank you, Dr. Aman. So now we move on to our next paper. Before that, I'd like to announce that all the cases which were you about to discuss in the case-based discussion has already been discussed in this. So I think we'll end our discussion after Dr. Anand Raja's talk and what he has to say about a critical review of a recently published paper. So over to you, Dr. Anand Raja.
Hi, thank you so much, Keval, for giving me this opportunity to share, my insights on what needs to be done. Is my screen visible, and can you hear me?
We can hear you. We can hear you.
Right. So I've been asked to review this paper on inguinal lymphadenectomy for penile cancer. It's an interim report from a trial comparing open versus video endoscopic surgery using a within patient design. So this paper came out in February 2024. It came out in a decent journal, the European Urology Focus. As you can see, the journal is kind of going up in impact factor. It was 1.72 in 2022. It is 2.46 in 2023. It shows, so that's a good thing. I mean, it's a good article published in a decent journal. And it also has a within patient design, which means to say that the patient serves both as, both the control arm and the intervention arm, or both the intervention arm are within the same patient. So that accounts for a lot of the confounding factors are taken care of. What they basically did was they randomly allocated participants to different conditions and all participants take part except take part in all conditions of the experiment. So the same patient is there participating in everything. So the only confounding factor is the treatment that was given to each of them. So basically what they did is they so again, coming down, does the abstract explicitly state the primary end design? As you can see here, it just says our aim is to compare the feasibility and safety of open inguinal lymphadenectomy and video endoscopic. So, I mean, just saying that, feasibility, what does feasibility mean? I mean, these procedures have been around for a while. So feasibility doesn't tell us too many things. Safety also doesn't tell us many things. It's slightly better when it comes to outcomes. They say that the primary outcomes was safety for veil lymphadenectomy. Again, safety is a very vague term, could have been slightly better defined. And but the secondary also, they say intraoperative and postoperative morbidity rates and surgical outcomes. Again, these are pretty vague terms. It is better to nail down what is it that they exactly want. There is no mention about toxicity report in the abstract. So if you read the abstract, the whole paper, you don't get too much information on what was actually done. It gets slightly better when they come to the conclusion. Does the concluding sentence of the abstract pertain to the primary endpoint? So it probably does. They do say that we compared the outcomes of two different surgical techniques to remove lymph nodes, the open in one groin and the endoscopic, the veil in the other groin, and they found out that the veil assisted keyhole seems to result in a lower rate of complications. Again, would have been slightly better to define what they meant as lower, but this is slightly acceptable. Again, coming to the main paper, so is what they said. I'm so sorry. Can you see this? Yeah. So is the question scientifically relevant? The nodal prognostic factor, what they have done is that they did not pre-specify between the CN0 and the CN plus groins. They just said, for all groins, whether they were CN0 or CN, one side they did the total inguinal lymphadenectomy by open approach, and the other groin they did it by the endoscopic approach. So only the approach differed. They did not take into consideration that the CN0 groin, you only needed to do a staging inguinal lymphadenectomy. They ended up doing, a therapeutic inguinal lymphadenectomy. So they did not take this, strike this balance into account, which is again a negative factor in this trial. Is this study trial, is this original? Keval, is hosting this session. So Keval has published his own paper on open versus veil versus robotic veil. There have been a plethora of other papers. There is a systematic review here. There is one more paper, can video endoscopic inguinal lymphadenectomy achieve lower morbidity than open inguinal lymphadenectomy? There's a prospective study that has compared the veil and the radical inguinal lymphadenectomy over an 8-year period. There is one more paper, the landmark paper by Machado et al. on veil, whether it is a minimally invasive procedure, which has kind of established this as one of the standards. So in a nutshell, there are a plethora of papers that are comparing the same, that have tried to answer the same question on open versus inguinal lymphadenectomy. A systematic review is also available. There's a lot of data on robotic veil. So it's not an original study question, and it nothing unique about what they're trying to answer. The last sentence of the introduction should actually clearly state the research question, which it does. It does say that the research question and the hypothesis are really tested. What was the objectives and the hypothesis stated clearly? Yes, they do state the hypothesis clearly, and they do state the aim of the current study very clearly. So this is the PICOT study, randomized controlled trial. So all the P, the I, the C, and the O and the T's have been very accurately done. So it does this aspect alone, all the boxes are checked. The ethics approval, trial design, everything is very correctly mentioned in this paper. The sample size calculation, again, they haven't mentioned why is it that they came about this sample size number, about 17 patients, who were included, who were initially screened, only 14 were included. I'm not so very sure that any sample size calculation went into this, just that they were able to recruit 14 patients and 28 groins in the study period. Blinding was not possible. It was an open label design because you can't hide an open and a robotic inguinal lymphadenectomy in the same patient. Randomization was again accurately done. The stats again were very correct. The baseline characteristics, again, now coming to the results of the study. So as you can see here, the BMI was 29 with a very narrow range between 26 and 32. We do know that, as was also mentioned by previous speakers, the BMI can range very widely from the very low to the very high. So whether the results of this study, especially in terms of morbidity, can be applied to everyone. Second, like I said before, the CN0 were 21 patients, the CN plus were 21 groins, the CN plus were 7 groins. So they did inguinal lymphadenectomy for all. So the 21 groins that were there were probably overstaged. Again, the numbers are slightly different when you come. The number is the same, 28, but I probably guess that one of those groins, the 21, actually one of them turned out to be node positive. So that's why this difference is there. Nonetheless, 20 patients were pathologically negative. So instead of offering just a superficial inguinal lymphadenectomy, they were offered both a superficial and deep, over-treating a lot of patients and possibly producing morbidity in 20 more groins than was actually needed. The saphenous vein was preserved in all veils, 20 open patients. Now we do know that, Amitabh presented a wonderful video where he's preserved the saphenous vein. But as part of traditional teaching is that the saphenous vein is taken down at the caudal end of the dissection for all patients, but it was preserved in all the veils and in some of the open lymphadenectomy. So when you preserve the saphenous vein and make an attempt to preserve it, we know that it kind of gets inserted into the femoral vein at the medial most part where the node really comes positive. So there's a chance that you might lead microscopic disease on the veins. So they were over treating the N0s and under treating the N plus, where the saphenous vein was actually preserved potentially. And they were using both staging and radical therapy in the same patient. Again, whether you could do it or not, is it comparable? It is a little bit doubtful. So like I said, the saphenous vein was preserved in 12 patients in the open and all 14 groins in the veil. The mean number of nodes again harvested were 3 and 2, which was again comparable. Now we really come to this. This is a very important slide because this is what this whole slide is all about. The mean time to drain removal, if you look at the open inguinal lymphadenectomy, was 27 days compared to 15 days for the video endoscopic approach. I fail to understand why it would be that in the open lymphadenectomy, the drain output was so much higher. Everything is right in front of you. There is more chances that you can actually ligate the lymphatics and the soft tissue, and you can suture them off. So technically, the drain output should be lower in the open lymphadenectomy, whereas it's the opposite in this study, and they have not really explained as to why that is happening. A mean length of hospital stay, they've said, is 5 days. Would have been better to talk about the open and the lymphatic, the video endoscopic separately, which they have not done. The VAS score again is the same. Again, important here is that they talk about recurrence-free survival at 1 year. They talk only about 13 patients. The cancer-specific survival, again, they've only spoken about 13 patients. If you remember, it was actually 14 patients with 28 groins, and they haven't mentioned what's happened to this one patient and why is it that is not reported. That is not very clear. So that has to be taken with a pinch of salt. Again, very important here that one of the main reasons, as Dr. Tarun also mentioned in his video, that one of the main reasons why the video endoscopic approach came about is because of the skin toxicity, skin problems, skin necrosis of the open approach compared to the endoscopic approach. But very strangely, we observe here that whether they did it open or whether they did the video endoscopic approach, there were not, they did not observe, they stated that we did not observe any skin necrosis in either group. So very strangely, the skin morbidity was the same. The only difference was the time to drain removal. I mean, I'm really perplexed as to how this happened. Maybe they were, expert surgeons who have a lot of experience in open inguinal lymphadenectomy. Again, the overall survival outcome, they mentioned the OS, again, only for 13 patients. 1 year is too small a time to really come into any conclusion at all. Again, there have been multiple other studies here. The well-read RCT is actually try to see whether there is a feasibility to do an RCT or not in this condition. And all these studies have mentioned about the intra-op details, cutaneous complications, number of nodes received, recurrence rates, so on and so forth. The recurrence rates were not very clearly mentioned in this paper. So if I have to conclude, I would probably say that there is nothing really novel in this paper because a lot of other data has already gone into this. Oncological data is not mature. It will probably come in a subsequent paper. There was over treatment of the N0 groins. There was under treatment of the N plus groins, probably because of the saphenous nerve preservation. And they kind of grouped everything together, the CN0, the CN plus, and try to homogenize it and compare both, which I didn't think was a very appropriate thing to do. So very little to take away from this paper, very little for us to change practice based on this paper. Thank you so much.
Thank you,
I think
sir.
I will stop sharing.
Thank you. Thank you for very detailed analysis of the paper. One point which I also wanted to make is that, like, the paper state that the operative time is same for both the groups. So again,
Exactly.
That has to, like, the learning curve has to be reached before. So maybe the surgeon over there have already been practicing laparoscopic veil for many years, and then that they did this trial. That can be one of the things. Okay, one thing which I wanted to tell you is that okay, although the number is very less, small sample size, but CA penis is such a disease where there is lack or scarcity of data for which are high level evidence. So this is one attempt to do that. One other attempt is also been made by Dr. Ben. Sir, can you tell us how much cases are being recruited, or how much is your in the trial which you mentioned that?
Yeah, so because it's a feasibility study, we're recruiting 50 patients. So hopefully randomizing 25 and 25. We're at 49. So we're very close to recruiting our final patient, and hope that therefore data will be out next year, because the follow-up is a minimum of 6 months. It's not necessarily looking at survival, so short follow-up. We're looking more at the complication side of things as well as the feasibility, and there is going to be a qualitative point to it, interviewing the patients that have declined, because actually there is not a big number, but a small and significant number of patients that have declined to undergo randomization and have decided to stick with the traditional open technique. So we're going to do some qualitative research and some interviews to try and understand that decision making as well. But yeah, hopefully data next year.
Dr. Anand. Yes, sir. What do you think? Yeah. What do you think would be the ideal time when we can, just tell that this is the time which we should be taking for calculation of survival, overall survival of recurrence-free survival? What would be the ideal time?
So we do know that most penile cancer recurrences, when they happen within the first 2 years. If you've done a suboptimal job, they happen within the first 6 months. But to talk about anything about local recurrence rates, systemic recurrence is a different issue. They can happen earlier. But anything to do with the local recurrence, at least a 2-year follow-up, if not more, I think I would need before I talk about local recurrence or oncological outcomes. I'm not sure if Dr. Ben or others agree with me, but in my book, it will be at least 2 years, if not more.
Okay. So, yeah, I'll come back in on that, and I agree. 2 years should be sufficient to see the vast majority of recurrences. We recently presented a paper at the EAU that suggested that maybe CT follow-up could be stopped for node positive patients around the 2 to 3 year mark, because all their survival curves just plateau. So I agree. I think 2 to 3 years would be sufficient. I think the other really important point to take home about minimally invasive groin surgery is that it's not to be done on larger nodes. This is for CN0 patients if you don't have sentinel nodes, or CN1 patients or PN1 patients where you've done their sentinel nodes and you've got a small focus of cancer. We've limited it in VELRAD to 15 millimeters. Anything bigger than 15 millimeters, we think should be open surgery, because if you start fracturing those nodes, you've lost the cancer side of the surgery. So I think it's really important not to take on too larger nodes with a minimally invasive approach.
Point very well taken, sir. So with that, I think we come to end of our webinar today. I thank Dr. Sujata madam. I also thank Dr. Before that, I'll hand over the mic to our past president, Dr. Ajay Chawla sir. But first of all, I'd like to thank all the speakers, all the panelists, all the videos. And I'd like to thank our international speakers, especially Dr. Ben, for being here, sparing his 2 years from his busy schedule. 2 hours from his busy schedule. Thank you, sir, for being here. Over to Dr. Chawla, sir, for concluding remarks. Dr. Chawla and Dr. Sujata, madam.
I think before Dr. Chawla joins, I would definitely like to say thanks, a big thanks to Dr. Ben, because he has spent his time from his active schedule. I think it must be in the afternoon time there in UK. And thank you for your words of wisdom and your participation and presence throughout the seminar. It's a great privilege. And of course, I think all of the speakers whom you spoke during the seminar, and the videos by Dr. Amitabh and Dr. Tarun, Ravi, Amandeep, and Dr. Ganesh, and you yourself, Keval. I think you did a lot of thinking and about the questions and the format for this seminar. I'm extremely grateful to you for your time and devotion. So I think if Dr. Chawla is not around, we'll conclude.
Yeah, ma'am, just I'll just congratulate
thanks,
Keval.
definitely.
Yeah, I'll congratulate Keval for scripting a very nice program and selecting a very, very excellent speakers, international speakers. Dr. Speiss and Dr. Benjamin's talks were excellent. I think covering whatever latest update is there in this subject. The national faculty, including Dr. Ravi, Dr. Tarun, Jindal, and Dr. Amitabh, their videos were so nice and they're so pleasing to watch. He added with the two very nice papers for discussion for the review by, again, one by Amandeep and Anand Raja. They did a brilliant job. And I think adding to this is how Keval thought of quality questions for everybody. That was very nice of Keval. That means he did a lot of hard work in not only in scripting, but choosing the quality questions to be put to the international and the national speakers. Overall, a very enjoyable webinar. I think the residents will gain a lot from this, and probably they can review it time and again before they go for the exam. Thank you, ma'am, and thank you, Keval. Once again, congratulations. Very good job.
Thank you, sir. Thank you, sir. Thank you, madam, for providing this opportunity.
Yeah. Good night and bye.
Good night.
Thank you. Bye.
Thank you.